The head surgeon grabbed her by the arm and shoved her out of the trauma bay in front of 30 witnesses. No apology, no hesitation, just a dismissal so complete it didn't even register as cruelty. It registered as routine. She was a nurse. He was God in a white coat. That was the order of things at Redwood Regional Medical Center, and nobody questioned it. Nobody except the doors that blew open 40 seconds later. Because rolling through those doors on a gurney, bleeding from a wound that only one person in that entire building knew how to treat, was a decorated military officer. And standing in the hallway, still straightening her scrubs from where she'd been shoved, was the only person who had ever seen that kind of wound before. In a desert, under fire, with no OR and no backup and 17 soldiers counting on her hands. They threw out the one person who could save him. If the story already has you leaning forward, follow along, hit like, and drop your city in the comments. I want to see how far this story travels. Let's go. The shift started at 6, and by 6:14, Emily Carter already knew it was going to be one of those nights. She'd learned to read emergency departments the way other people read weather. Not from any single sign, but from the accumulated pressure of small things. The way the triage nurse kept exhaling through her nose without looking up. The backup of gurneys in the intake corridor. The attending who walked past twice without stopping, which meant he was circling a problem he hadn't decided how to handle yet. Redwood Regional Medical Center had that low electric hum tonight, the kind that preceded something bad the way certain silences precede thunder. Emily clocked in, tied back her hair, and took her assignment from the charge nurse without comment. Bay 4 through 7, said Donna Price, not looking up from the tablet. Overflow from the highway pile up on the 9. We've got walking wounded backed up to the door and 2 critical still en route. How critical? Trauma level critical. Briggs is primary. Emily absorbed that without reacting. She took the tablet Donna extended, scanned the intake notes, and walked toward Bay 4. She was 30 years old and looked younger, which was part of the problem at Redwood Regional. Or rather, it was the surface of the problem. The actual problem was harder to name, and most people didn't try. She was quiet in a building full of people who equated volume with competence. She wore plain scrubs, no pins, no credentials visible beyond her badge. She didn't push, didn't perform, didn't explain herself unprompted. In a hospital that ran on hierarchy as much as medicine, that made her invisible in the ways that cost you. Bay 4 was a 38-year-old male, lacerations to the forearm, possible fracture. Emily introduced herself, assessed the arm, and began cleaning the wound with the efficiency of someone who had done this 10,000 times, which was close to accurate. The patient, he said his name was Marcus, said it twice like he needed the anchor, was shaking from adrenaline and trying to cover it. "You doing okay?" she asked, not looking up from the wound. Yeah, my wife's still in the car. They said she's in Bay 6, Emily said. I checked the board before I came in. Her injuries are less severe than yours. She's stable. Marcus stopped shaking quite so hard. You checked. It seemed like something you'd want to know. She finished the cleaning, applied a pressure dressing, and flagged the chart for X-ray on the forearm. She moved to Bay 5. Bay 5 was a teenage girl, maybe 16, with a head lack and the glazed look of someone who'd been sitting in fear adrenaline for too long. Emily ran a concussion check, talked her through it, and was midway through charting when she heard Dr. Nathan Briggs' voice carrying from the corridor. She had worked at Redwood Regional for 7 months. In that time, she'd developed an accurate taxonomy of the hospital's attending physicians. Most of them were competent and overextended. A few were exceptional. Nathan Briggs was something else, skilled enough to have never been meaningfully challenged, which had calcified into a kind of authority that he wore like a second skin. He was 44, chief of emergency surgery, and had the absolute certainty of a man who'd been told he was the smartest in the room often enough that he'd stopped questioning it. He was in the corridor talking to a resident named Pollard, and his voice had that particular carrying quality of someone who had never learned to modulate for proximity. Tell me why we have agency staff in the trauma bays again? Short-staffed, Dr. Briggs. The Johnson situation. I don't care about the Johnson situation. I care about having unvetted personnel in my department during a mass casualty event. Emily didn't look up from her charting. She heard him approach before she saw him. the change in how people moved in the corridor, the slight redistribution of space around him. Then he was in the doorway of Bay 5, looking at her the way a man looks at something he's decided is out of place. "You're Carter?" "Yes." "What's your assignment tonight?" "Bays 4 through 7. Overflow intake from the highway incident." He looked at her chart, then at the patient, then back at her with the evaluating stare of someone running a calculation. "You flagged the concussion protocol." "She's presenting with symptoms. It seemed appropriate." "She's presenting with a headache after a car accident. That's not the same thing." He said it loudly enough for the teenager to hear, which was either carelessness or intention. "We don't run full concussion workups on every soft tissue. She has unequal pupil response," Emily said. "Left pupil is 2 millimeters larger than the right. I documented it in the chart." A beat. Briggs looked at the chart again. He looked at the patient. He looked at Emily with an expression that was hard to characterize. Not embarrassment exactly, but the close cousin of it that presents as irritation. "I'll have a resident complete this assessment," he said, and walked away. The teenager watched him go. "Is he always like that?" "Some people are," Emily said. She made a note in the chart and moved to Bay 6, where she found Marcus's wife, Linda, the chart said, 41, with a wrapped wrist and 3 cracked ribs and the held-together expression of someone who'd been told to breathe shallowly. "Your husband asked about you," Emily said. Linda's jaw unclenched slightly. "He's okay?" "He'll need an X-ray, but yes." "He always does this, gets hurt worse than me and spends the whole time worrying." There was something fond in it, not frustration. Linda winced as she adjusted position. Can someone tell him I'm okay? He'll spiral if nobody tells him." "I'll make sure he knows," Emily said. She was doing exactly that, stopping by Bay 4 long enough to tell Marcus that Linda had asked about him, watching the specific relief of a man whose fear has been given an exit, when the radio at the nurse's station cut out. Not lost signal, cut. One moment it was background noise, the next it was silence, and in an emergency department silence from a radio meant one thing. Donna Price was already on her feet. The security desk at the main entrance had been on the radio with them every 30 minutes during the mass casualty event. The silence meant they had switched to a priority frequency, which meant something was incoming that warranted it. Emily moved toward the triage station without thinking about it. Old habit. When information goes quiet, you move toward the source. Donna was on the desk phone. She listened for 8 seconds, said, "Copy," and hung up. "Incoming trauma," she said to the room. "Military, single patient, ETA, 4 minutes. They're calling ahead." "Who's calling ahead?" someone asked. "Military did. Said the patient requires specialist trauma intervention. They're requesting our OR status." Donna was already paging the trauma team. "Briggs is primary." Emily felt something shift in her. Not urgency exactly, but recognition. Military calling ahead to a civilian hospital meant the patient was beyond field stabilization, and the situation was beyond the usual routing to a military medical facility. That combination meant something specific about the injury type, or the location, or both. She turned back toward Bay 7, where her last unassessed patient was waiting. She was 3 steps from the bay when Dr. Briggs appeared in the corridor ahead of her. He was moving with the brisk, purpose-heavy stride of a man who had decided he was the central figure in the next scene. Behind him were 2 residents and a surgical tech. He stopped when he saw her. "Carter? Dr. Briggs?" "Trauma protocol is in effect. That means all non-essential personnel clear the main trauma bay corridor." He said it like he was reading from a policy document he'd written himself. "Agency nurses are non-essential during trauma activation. I have an unassessed patient in Bay 7. I'll have someone cover Bay 7. Clear the corridor." Emily looked at him for a moment. Something about the cadence of the radio call was sitting in her chest like a splinter. The specificity of the language, specialist trauma intervention, the fact that they'd called ahead at all. Military medical liaisons didn't call ahead to civilian hospitals unless the patient's injury profile required knowledge that wasn't assumed standard. "What's the mechanism of injury?" she asked. "That's not your concern." "I'm asking because there's a limited set of injuries that would prompt a pre-arrival call requesting specialist intervention. If the patient has a penetrating thoracic wound from a blast, Carter, his voice had dropped into a register that was less instruction and more warning. I won't say it twice. Clear the corridor, or I'll have security remove you. Around them, the trauma bay was assembling. Nurses, a respiratory tech, the on-call anesthesiologist moving with the focused efficiency of people who had practiced this enough times that it didn't require thought. Nobody was looking at Emily and Briggs directly, but everyone was aware of the exchange. Emily said, I'm trying to help. I don't need your help. Clear the corridor. She turned and walked back toward the nurses' station. Donna caught her eye from behind the desk and gave the slight, practiced non-expression of a woman who had seen this dynamic before and had learned not to make it worse by reacting to it. Emily pulled up the Bay 7 chart on the secondary terminal and began reviewing it without sitting down, because the entrance to the trauma bay was visible from where she was standing. 2 minutes passed. Then the ambulance bay doors opened. She heard the gurney before she saw it, the specific rattling cadence of a trauma transport moving at speed. And then it was through the doors, and she had 1 second of visual before the trauma team surrounded it. 1 second. But a second was enough. The patient was male, 40s, in partial military uniform. Not a field uniform, something else. Something dress-adjacent that had been cut away at the torso. His face was the gray-white of acute blood loss. An IV was running wide open in his left arm. There was a pressure dressing on his right lateral chest, and the dressing was saturated. Emily had seen that saturation pattern 3 times in her life. Each of those times had been in a forward operating base medical station. And each of those times the patient had been within minutes of a tension pneumothorax that would kill him faster than the original wound. She was moving before she'd finished the thought. Not running. Running created panic in a trauma bay, and panic killed patients. But moving with the deliberate speed of someone who knows exactly where they're going. She was 6 feet from the gurney when Briggs stepped directly into her path. He didn't touch her this time. He didn't have to. He simply placed himself between her and the patient with the calm authority of a man who had never needed to defend his position physically because his position had never been seriously threatened. I told you to clear the corridor. That dressing is going to fail in under 3 minutes, Emily said. She kept her voice flat. The cavity pressure is building. If you don't decompress, we're handling it. You're not handling it, you're assessing it. There's a difference. She could see past his shoulder. The trauma team was working, but they were working through a checklist, not through recognition. They hadn't seen what she'd seen. They were looking at hemorrhage control and missing the pressure. Dr. Briggs, I'm asking you to listen to me for 30 seconds. You're asking me nothing. He turned to the security officer near the entrance. Martinez, please escort this nurse to the waiting area. Officer Martinez, early 30s, apologetic in the way of someone following an order they hadn't chosen, stepped toward Emily. She didn't move. Not immediately. She looked past Briggs at the patient on the gurney, and she looked at the monitor readings that were just visible from her angle, and she calculated. Then she said quietly enough that only Briggs could hear, a patient doesn't care about titles. They care who can save them. Briggs's expression didn't change. Martinez touched her arm gently but firmly, and Emily let herself be guided backward, away from the trauma bay, away from the gurney, away from the patient whose chest was filling with air that had nowhere to go. She stood in the corridor outside the trauma bay and said nothing. Martinez didn't speak either. He had the look of a man waiting for the moment when his job would stop feeling like this. Through the window of the trauma bay door, Emily could see the team working. She could see Briggs directing them. She could see the monitor, and she watched the numbers with the specific attention of someone reading a language most people in the building didn't know existed. 90 seconds. The oxygen saturation began to drop. 2 minutes. The heart rate climbed. Emily's hand was in her pocket, wrapped around nothing, because there was nothing to hold. The doors to the ambulance bay blew open again. Not a second ambulance. Not another patient. 4 people in uniform, moving with the coordinated economy of individuals who had learned to move that way in environments where moving wrong had permanent consequences. 2 were officers. She could read the rank insignia from where she stood, colonel and major. and two were in the kind of civilian clothes that read as active duty trying not to look it, which she recognized because she had worn those clothes herself. They didn't stop at the reception desk. They didn't ask for direction. They moved toward the trauma bay with the absolute certainty of people who had been given intelligence about where they were going before they arrived. The colonel was maybe 50, with the kind of face that had been shaped by decisions made under pressure into something that looked less like age and more like geology. He was scanning the corridor as he walked, not anxiously, but systematically, the way you scan an unfamiliar space when you're responsible for what happens in it. His scan reached Emily. He stopped, not slowed. Stopped. Full stop, mid-stride, with the sudden absolute stillness of a man who has just encountered something he was not expecting to encounter. Emily felt the recognition a half-second before he spoke, and she recognized it as the specific weight of a past she had set down deliberately 7 months ago when she had walked into Redwood Regional for her first shift and chosen, consciously, with full knowledge of what she was choosing, to be Emily Carter, nurse, and nothing else. "Carter," the colonel said. She said, "Colonel Voss." Behind him, the major had stopped as well. The two civilians had taken positions flanking the corridor and entrance with the automatic efficiency of trained security. Voss looked at her badge. He looked at her scrubs. He looked at the trauma bay behind her, and then back at her. And in the second it took him to reconstruct the situation from those 3 data points, Emily watched him understand exactly what had happened and exactly what it meant. From inside the trauma bay, an alarm began to sound. Not the continuous low alarm of a patient being monitored, the sharp, cycling alert of a patient crashing. Emily turned toward the window. On the monitor, the number she had been watching had reached the threshold she had been predicting. Oxygen saturation, 78. Heart rate, 134. Blood pressure dropping. Inside the bay, she could see the trauma team accelerating, and she could see Briggs, and she could see, from the way he was moving, the way his hands went to the patient's chest and then paused, that he was encountering something he hadn't prepared for, hadn't recognized, didn't have a practiced response to. The colonel's hand was on the trauma bay door. Emily said, "Colonel, the patient has a retained pneumothorax. Pressure's been building since before he arrived. You need to needle decompress the right second intercostal space, mid-clavicular line, immediately. The team inside hasn't recognized it yet." Voss looked at her. "Now," she said. He pushed through the door. She heard his voice once, cutting through the organized noise of the trauma team. "Stop. Listen to me. Right second, ICS, mid-clavicular. Now. Do it now." A beat of silence. Then the sound of movement, and the particular physical release of a tension pneumothorax decompressing. And then, a few seconds later, the monitor alarm cycling down. Martinez, standing beside Emily, had stopped breathing. He started again. Through the trauma bay window, Emily watched the patient's numbers begin to climb back toward survivable. Oxygen saturation rising, heart rate slowing, blood pressure stabilizing. She was still watching when the trauma bay door opened again and Colonel Voss stepped back into the corridor. He looked at her with an expression that was not surprise. He was past surprise, but something that lived adjacent to it. The expression of a man recalibrating. "He's going to make it," he said. "Probably," Emily said, "if they manage the hemostasis correctly." "You knew from outside the room." "I've seen the injury pattern before." Voss was quiet for a moment. His jaw worked slightly, the way jaws work when someone is deciding what to say. "Why weren't you in there?" Emily looked through the window at Briggs, who was standing with his back to the glass, directing the stabilization with the focused intensity of a man who did not yet know the full shape of the evening he was inside. "I was asked to wait in the corridor," she said. The colonel looked at Briggs. Then he looked back at Emily. And in his expression was the specific quiet anger of a man who has seen something preventable happen and is already calculating what needs to come next. Emily said nothing else. She didn't need to. Down the corridor at the nurse's station, Donna Price had stopped pretending to look at her tablet. She was watching. 3 residents had found reasons to be in the corridor. A surgical tech had her back against the wall, very still. The alarm had stopped. The patient was alive. and Nathan Briggs inside the trauma bay had not yet turned around to face the window. When he did, he would see Colonel Voss, he would see the uniform, he would see the expression on Voss's face. And he would begin, in the slow, cold way of a man who has been certain for too long, to understand that the evening was not going to end the way he had planned. Briggs turned around at 9:47 p.m. Emily knew the exact time because she was looking at the clock above the nurse's station when it happened. Not deliberately, just the kind of incidental precision your brain records when it knows something is about to shift. The second hand was between the 9 and the 10. The trauma bay had been quiet for 4 minutes. The patient's numbers had stabilized into the narrow range of someone who had been very close to dying and had been pulled back from it. Not cleanly, not without cost, but back. Briggs turned, and he saw Voss. The colonel was standing at the window. Not looking in, he had been looking at Emily for the last 2 minutes, asking her questions in the clipped information-gathering register of someone conducting a rapid field assessment. What's the patient's likely diagnosis beyond the pneumothorax? What's the recommended management sequence? What are the risk factors for secondary deterioration in the next 4 hours? Emily had answered all of it, quietly, specifically, without editorializing. But when Briggs turned, Voss shifted his attention to the window, and the two men looked at each other through the glass. It lasted maybe 4 seconds. 4 seconds is a long time when both people understand what's being communicated. Briggs broke first. He turned back to his team, said something Emily couldn't hear, and the team continued working. But the set of his shoulders had changed. Something in the line of his spine had gone careful in a way it hadn't been before. "He knows something's wrong," Martinez said beside her. Emily glanced at him. She had nearly forgotten he was there. "He's been doing surgery for 15 years, she said. "He knows when a room has shifted." "Is the patient actually going to be okay?" "The immediate crisis is managed. The next hour is the critical window." She looked at the monitor readouts visible through the glass. "They need to get him to an OR for the hemorrhage. The chest decompression bought time. It didn't fix the underlying problem." Voss had turned back from the window. "What's the surgical requirement?" "He needs a thoracotomy to address the source bleed, possibly a damage control resection depending on what they find. The dressing they had on him in transport was doing work, but it was losing ground." She paused. "He needs someone who has done this kind of repair before, not in a controlled OR environment, the kind of surgical setting where you're managing a cavity that doesn't behave the way the textbook says it will." Well, Voss was looking at her with the measuring quality she remembered from a different context. A tent in a forward area. A man whose judgment she had learned to trust because he applied it the same way, whether the news was good or bad. "You have OR privileges here?" he asked. "No," she said. "I'm a nurse. I don't perform surgery." "But you've assisted in procedures like this." "In field settings, yes. I've assisted, and in 2 instances where there was no physician present, I've performed damage control procedures under remote physician guidance." She said it the way she said everything, flat, without drama. "That's not a credential that transfers to a civilian hospital." "It transfers to me," Voss said. "Colonel, I'm not asking you to perform surgery, Carter. I'm asking whether you can be in that room and make sure the person performing surgery does it correctly." Before she could answer, the trauma bay door opened and Briggs stepped out. He had the controlled expression of a man who had decided in the last 4 minutes how he was going to handle this, which meant he had decided to handle it from a position of authority and hope that was enough. He stopped when he saw Voss. He looked at the rank insignia the way people look at things they need to assess before they respond. "Colonel," he said, "I'm Dr. Nathan Briggs, Chief of Emergency Surgery. Your officer is stable. We're preparing to move him to the OR." "I know he's stable," Voss said. "I know why he's stable." A beat. The team responded appropriately to the team responded after I intervened, based on information provided by a member of your staff who you had removed from the corridor. Briggs's eyes moved to Emily. It was a brief movement, the kind that people make when they're trying not to make it and fail. Nurse Carter was creating a disruption during a trauma activation. Standard protocol requires Standard protocol, Voss said, requires the most qualified person in proximity to a patient to be involved in that patient's care. Are you telling me that Nurse Carter is not the most qualified person in this building to assess a combat-related penetrating chest wound? Briggs paused 1 second too long. I wasn't aware of her background, he said. Her background, Voss said, is that she spent 6 years as a military trauma nurse in 2 active conflict zones, ran a forward surgical team at FOB Keller during the Adari Valley operation, and was decorated for actions during a mass casualty event in which she managed 12 critical patients simultaneously with no physician support for 11 hours. He said it without inflection, the way someone recites facts they have known for a long time. She has forgotten more about combat trauma than most surgeons in this country will ever learn. The corridor had gone very quiet. Emily could feel it, the particular stillness of a space where people have stopped pretending not to listen. Briggs looked at her again. This time the look was longer and more complicated and harder to read. She watched something move through his face that wasn't quite shame and wasn't quite anger, something between them that hadn't found its name yet. The patient needs to get to the OR, Emily said. She wasn't looking at Briggs, she was looking at Voss. Whatever else is happening right now, that's the priority. Voss looked at her, then he looked at Briggs. Agreed. And we'll continue this conversation afterward. Briggs nodded once and went back through the trauma bay door. Emily let out a slow breath through her nose. Martinez said quietly, The patient needs to go up in the next 10 minutes, Emily said. Can you make sure the elevator is cleared for transport? Martinez blinked, then nodded and moved away to do it. Voss turned to the major behind him. Okafor, she'd gathered, from the brief exchange she'd observed when they'd arrived, and said something in a low voice. Okafor moved toward the nurse's station with a tablet. The 2 civilians had repositioned themselves near the entrance to the trauma bay, and Emily understood without being told that they would be staying with the patient through the transport and into the OR waiting area. You didn't correct him, Voss said. She looked at him. What? Briggs, you didn't tell him what you knew when he was making the wrong call. You let him remove you. I told him what he needed to know. He chose not to hear it. You could have pushed harder. Emily looked through the trauma bay window at the patient, who was being prepared for transport. Lines secured, monitor reconfigured, the careful choreography of moving a critical patient without introducing new risk. Pushing harder in that moment would have made it about me and Briggs, she said. That takes attention off the patient. 30 seconds of posturing and he's 2 minutes closer to crashing. She paused. I said what I needed to say. I said it clearly. The decision was his. Voss was quiet for a moment, then, same as you always were. That's not meant as a compliment in every context, Colonel. No, he agreed, but it is tonight. The transport team came out of the trauma bay with the gurney, and Emily stepped back to give them room. As the patient moved past, she looked at his face for the first time without crisis framing it, without the monitor and the alarm and the pressure of seconds counting down. He was older than she'd estimated, maybe late 40s, with the kind of weathering that comes from years outdoors in difficult conditions. She didn't know his name, she didn't need to. He was breathing. That was enough. The gurney moved toward the elevator, flanked by the transport team and by 2 of Voss's people. Voss walked with them for a few steps, then stopped and turned back. I want a full report on what happened tonight, he said. Timeline, sequence of decisions, who was where and when. I want to understand everything that occurred between the patient's arrival and stabilization. You'll want to talk to Donna Price at the charge desk, Emily said. She has better visibility on the full sequence than I do. I'll talk to her. I'll also talk to you. He held her gaze for a moment. And I'll talk to the hospital administration. Tonight. He left. The corridor began to breathe again. Emily stood for a moment in the specific aftermath of something that had been very loud and was now suddenly quiet, feeling the particular dissonance of that transition. Then she turned and walked back to the nurse's station, because she had patients in bays 4 through 7, and 3 of them hadn't been properly closed out on the chart yet. Donna Price was behind the desk. She didn't say anything immediately. She had the look of someone who needed a second to organize what they'd just witnessed into a form that could be spoken. Finally, she said, How long have you been an Army nurse? I was in Army, Emily said. Navy Nurse Corps. How long? 6 years on active duty, 2 combat deployments. She picked up the tablet with the Bay charts. Then I got out. Why? Emily looked at her. Because I wanted to. Donna absorbed that. She had the sense, Emily thought, to recognize when the real answer to a question was less important than the fact of the question being answered at all. Briggs is going to be a problem, she said. He's already a problem. I mean specifically for you, tonight. He's going to… Donna. Emily kept her voice even. He's in the OR. I have 4 patients who still need charting and a Bay 7 admit I haven't properly assessed. Can we deal with what's in front of us? Donna looked at her for a long moment. Then she nodded and picked up her desk phone. Emily went to Bay 7. The patient there was a woman in her 60s who had been in the highway accident, soft tissue injuries to the neck and left shoulder, already assessed by a resident but not fully charted. Emily reintroduced herself and went through the assessment with the thorough patience of someone who had learned over years that the injury you're looking for is often not the one that's presenting loudest. The woman, she said her name was Rosa, that she'd been driving home from her daughter's house, that she'd seen the pileup starting and had tried to brake and hadn't been able to stop in time, kept apologizing for taking up space. You're not taking up space, Emily said. You're a patient. This is what the space is for. Rosa looked at her. You're very calm. It's a useful quality tonight. She finished the assessment, flagged the cervical strain for a collar and imaging, and moved back to the nurse's station to chart. It was 10:20. The emergency department had quieted from the peak of the mass casualty event. Most of the highway accident patients had been assessed, treated, or admitted, and the acute pressure had redistributed into the slower, steadier rhythm of a busy overnight shift. She was 20 minutes into charting when Dr. Pollard, the resident she'd seen with Briggs earlier, appeared beside the desk. He was young, maybe 3rd year, with the tired face of someone who had been working since 6 a.m. and the careful expression of someone who had been watching the evening develop and was not sure what it meant for him. Hey, he said. Hey, He stopped, started again. That was you tonight. You called the pneumothorax from the corridor. I called the pressure buildup. Colonel Voss directed the intervention. Pollard shook his head slightly. I was in the bay. I was looking at the chest, and He stopped again. I didn't see it. You were looking for what you'd been trained to look for, Emily said. Combat injuries present differently. The patterns are different. You don't learn them in a standard trauma rotation. How did you learn them? Repetition, she said, in environments where missing them was not recoverable. He stood there for a moment. He looked like he wanted to say something else and hadn't found the shape of it yet. He told us you were being disruptive, he said finally. Briggs. Before the patient arrived, he told the team that you were an agency nurse who was creating problems and that we should disregard anything you said. Emily looked at him steadily. Pollard exhaled. I wanted you to know that's what we were told before you came in, so that when you tried to… I want you to know why we didn't… He stopped. It was wrong. I should have listened anyway. The patient survived, Emily said. That's what matters. Is it, though? He said it quietly. Really? Because I was in that room following instructions from someone who was wrong, and I had information from you that was right, and I made a choice, and the patient almost died because of the choice I made. The directness of it was unexpected. Emily looked at him more carefully, at the tiredness and the specific kind of distress that comes not from external pressure, but from internal accountability. You're a resident, she said. You're trained to defer to attending physicians. That's not an unreasonable instinct. It's a bad instinct when the attending is wrong. Yes, she said. It is. She let that sit for a second. That's something you learn. Usually the learning costs you something. Pollard was quiet. Then he nodded, once, and walked away. Emily turned back to her charting. At 10:55, the OR called down. It was the scrub nurse, she identified herself as Taryn, and her voice had the clipped efficiency of someone who was still working and didn't have bandwidth for social framing. The thoracotomy is in progress. Dr. Briggs is lead. We have a situation. Emily straightened. What kind of situation? The source bleed is from the right pulmonary vein, proximal segment. Briggs is managing it, but he's... A pause, brief but telling. He's asking if there's anyone available who's familiar with non-standard vascular repair techniques in a compressed field. Emily processed that. Non-standard compressed field. Civilian OR language for a repair scenario that looked more like field surgery than a controlled hospital procedure. He's asking for me, she said. He's asking if there's anyone available, Taryn said again, carefully. With relevant experience. Emily set down the tablet. I'll be up in 4 minutes. She told Donna where she was going, changed into a fresh set of scrubs, and took the stairs because the elevator was still tied up with a different transport. As she moved, she was running the procedural sequence in her head, not because she needed to rehearse it, but because she had a habit of visualizing the shape of what she was walking into before she walked into it. Pulmonary vein, proximal, with a chest that had already been through a traumatic pneumothorax and was compromised. Briggs would be working in a field that was smaller than ideal, and with tissue integrity that was reduced. The angles would be bad. The exposure would be limited. She had worked in worse. The OR was on the 4th floor, second suite from the end. She pushed through the doors and was greeted by Taryn, who handed her a mask and gloves with the wordless economy of someone who had been working in this room for hours and had already assessed that the situation required action and not explanation. Briggs looked up when Emily entered. He was mid-procedure, both hands in the field, working with the focused intensity of a man who was doing something that was at the edge of what he could do. The patient's chest cavity was open, and the source of the bleed was visible. She could see it from where she was standing, could see why it was difficult, could see the angle problem and the tissue issue that was making the standard approach ineffective. "Carter," he said. "Dr. Briggs? I need another perspective on the repair approach." He said it evenly, without anything she could name as an apology. "The standard vascular clamp position isn't giving me sufficient purchase. The proximity to the bronchial branch is... Shift your entry angle 40 degrees lateral," she said. She was at the table, looking at the field directly. "If you approach from the standard anterior position, you're going to have to retract the bronchial tissue, which is already under stress. Come in from the lateral aspect. You'll have a narrower workspace, but the vein wall will be more accessible, and you won't be creating secondary compression." Briggs looked at the field. He looked at her. "Show me." She directed him through it, not taking over the procedure, but positioning her hands near his without touching, indicating the angle, talking him through the adjustment the way she had once talked a medic through a procedure he had never performed, in a tent, with artillery in the background and 6 other patients waiting. It took 8 minutes. When the repair was complete, the bleeding stopped, and the OR went through the specific exhalation of a room full of people who had been holding tension and could now release it. Taryn said, "Saturation holding at 94, pressure stabilizing." The anesthesiologist, a woman Emily didn't know, who had been managing the patient's airway with the quiet authority of her specialty throughout, said, "He's coming through." Briggs was looking at the field. Then he looked at Emily. "The lateral approach," he said. "Where did you learn that?" "F.O.B. Keller," Emily said. "Year 3. Field surgeon named Mac showed me because we had a casualty with the same anatomical presentation, and the standard approach would have taken too long." She stripped off her gloves. "He's going to need careful monitoring for the next 6 hours. Secondary pneumothorax risk is still elevated. And watch his... Carter." She stopped. Briggs was looking at her with an expression she couldn't fully read. It was too complicated, too many things at once. "Thank you," he said. She looked at him for a moment. "The patient's not out of the woods yet," she said, and walked out of the OR. In the hallway, she leaned against the wall for exactly 10 seconds. Let her shoulders drop. Let her hands unclench. Let the controlled focus of the last 4 hours find somewhere to go. Then she pushed off the wall and took the stairs back down to the emergency department because it was 11:15 and she still had charting to complete. Donna met her at the door to the stairwell with an expression that meant something had happened while she was upstairs. "What?" Emily said. "Colonel Voss came back down." "I know. He said he'd be talking to administration. He did more than talk. Donna had her arms crossed, the posture of someone who is trying to hold a large amount of information at a manageable distance. He requested the hospital's incident records for tonight, specifically the trauma bay entry log, the security footage from the corridor, and the radio communications during the patient arrival window. Emily looked at her. He also requested the employment records for... Donna stopped. Emily, he's filing a formal incident report with the military. He's alleging that a patient under military care was endangered by a civilian physician's administrative decision. The weight of that settled in the corridor between them. That's his call to make, Emily said. It's going to mean an investigation, formal. Hospital board, probably external oversight. Everyone who was in that corridor tonight is going to be interviewed. Donna was watching her carefully. Including you. I know. You don't seem... Donna stopped again. You knew this was going to happen. I knew it was one of the things that could happen, Emily said. There are other outcomes. This is a possible one. Does it bother you? Emily considered the question honestly, which she did with most questions. The right thing is happening, she said. The right thing is uncomfortable. Those two facts coexist. Donna was quiet for a moment, then, Your Bay 7 patient is asking about her discharge paperwork. I'll handle it. She was walking toward the bay when the nursing station phone rang. Donna picked it up, listened for 3 seconds, and called after her. Emily. Something in Donna's voice made her stop. There's someone from hospital administration at the front desk, Donna said. A woman named Harlan, deputy chief of staff. She paused. She's asking for Dr. Briggs. Emily turned. Briggs is still in the OR. I know. Donna's expression had gone careful in a specific way. She's asking for Briggs, but she has 2 people with her, and one of them is carrying a folder with a legal department header. The hallway felt very still. They're not here about the patient, Donna said. No, Emily agreed, they're not. She walked back to the nurse's station and stood there for a moment, thinking about the shape of what was moving through the building. Not like a wave, she thought, but like a tide. Slow and enormous and indifferent to individual obstacles. The legal folder, the military incident report, the security footage from the corridor which had caught everything. Briggs was still on the 4th floor, finishing a thoracotomy on a patient he had almost let die. He didn't know yet that the building had been accumulating evidence against him for the last 2 hours. He didn't know that the security camera in the trauma corridor, positioned above the entrance to Bay 1, angled for maximum coverage, had caught every second of what happened, including the moment he told Martinez to remove Emily from the corridor, and including the moment the alarm had started, and including the exact timestamps on all of it. He didn't know that Pollard, standing in the hallway right now and looking at the floor, had already written down everything he'd witnessed and had handed it to the charge nurse 15 minutes ago. He didn't know what was waiting for him when he came back down. Emily looked at the clock. 11:23. She looked at the OR status board, Suite 2, occupied approximately 40 minutes remaining. She thought about what Donna had said, about what Voss had said, about what Pollard had said, standing in the corridor with the honest, uncomfortable weight of a young doctor deciding what kind of physician he was going to be. She thought about the patient on the 4th floor, whose name she still didn't know, breathing through a chest she had helped repair. And then she picked up the tablet with the Bay charts and went back to work, because there were still patients, and patients didn't wait for anything. She was charting Rosa's cervical imaging results when the elevator opened. Not Briggs. Not yet. It was Voss, and behind him was a woman Emily didn't recognize, maybe mid-40s, in a business jacket with the badge of a federal agency clipped to her lapel. The badge was angled in a way that Emily couldn't read from across the room, but the jacket and the posture and the way the woman moved, with the specific efficiency of someone who went into rooms to extract information, told her enough. Not military. Not hospital administration. Someone else. Voss walked directly to the nurse's station. He looked at Emily with an expression that had shifted again. Less the careful assessment of the corridor, more the deliberate stillness of a man who had just done something that couldn't be undone and had made peace with that. "This is Special Agent Rourke," he said. She's been contacted by the military in connection with tonight's incident. She'll need access to the facility's records. Emily looked at Rourke. Rourke looked at Emily with the neutral, taking inventory expression of someone who made assessments quickly and kept them to herself. "Nurse Carter," Rourke said. "Agent Rourke. I'm going to need about 20 minutes of your time when you're available." "I have patience. I understand. Whenever you're available." Emily looked at Voss. Something was moving behind his eyes that she couldn't read at this angle or maybe at any angle. The specific opacity of a man who had set something in motion and was now watching it move. "Colonel," she said, "what exactly did you report?" Voss looked at her for a moment. "Everything," he said. Down the corridor, the elevator doors opened again. Briggs stepped out. He had changed out of his OR scrubs into a fresh set. He had the post-surgical look of someone who had been through 4 hours of focused, demanding work and had come out the other side of it, tired, but the particular tired that has competence underneath it. He was looking at his phone as he stepped off the elevator. He looked up. He saw Voss. He saw the woman in the business jacket with the federal badge. He saw Emily at the nurse's station. He saw Donna, who was watching him with an expression that had gone entirely neutral. And in the 4 seconds it took him to assemble those elements into a picture, Emily watched something happen in Nathan Briggs that she had not expected and could not look away from. Not the collapse of arrogance, not the dramatic confrontation she might have anticipated. Something quieter and more specific than that. The expression of a man who has just understood, all at once, the exact distance between where he thought he was and where he actually is. He stood in the elevator doorway for 1 second past when the doors should have closed, and then he stepped forward into the corridor. The hospital had gone very quiet. Agent Rourke was already moving toward him. Rourke moved the way investigators move when they've already decided on the sequence, not rushing, not telegraphing, just closing distance with the efficiency of someone who has done this enough times to have removed all the unnecessary motion from it. Briggs saw her coming and stood his ground, which was either composure or the instinct of a man who hadn't yet accepted that the ground had already moved. "Dr. Briggs," Rourke said, "I'm Special Agent Dana Rourke. I've been contacted in connection with an incident that occurred in this facility tonight, involving a patient under military jurisdiction." She produced a credentials case and held it open for exactly the time required, then put it away. "I'd like to speak with you." "I'm the Chief of Emergency Surgery," Briggs said. "I just finished a 4-hour procedure. If this is about the..." "It's about the period between approximately 21:30 and 21:52, Rourke said. "Specifically the decisions made during that window and their relationship to patient outcome." "The patient survived." "Yes," Rourke said. "He did." She let that sit for exactly 1 beat. "I'd like to understand the sequence of decisions that almost changed that outcome." Briggs looked at Voss, then at Emily. The look he gave Emily was brief and complicated, and she watched him decide in real time to set it aside, to file it somewhere he'd deal with later, because later was the only place he had room for it. "I'll speak with you," he said to Rourke. "I want a hospital attorney present." "That's your right," Rourke said. "We can arrange that. In the meantime, I'll need you to remain available and on site." She said the last 4 words with a specific quality. Not a threat, not yet, just a boundary being placed where a boundary needed to be. Briggs nodded and walked toward the administrative corridor. The elevator doors, which had been holding, finally closed behind where he'd been standing. Donna exhaled audibly. Then she looked at Emily and said, "You need to eat something." Emily almost laughed. "What?" "You've been on shift for 6 hours, and I watched you not eat the sandwich I put on the desk at 8. You need to eat something or you're going to crash." Donna was already reaching under the counter. "I have crackers." "Donna." "Crackers and whatever the vending machine situation is. It's not a full meal, but it's something." She produced a sleeve of crackers and put them on the desk with the determined practicality of a woman who managed crises by making sure the people around her were physically functional. "Eat." Emily took a cracker. She wasn't hungry. The adrenaline of the last 3 hours had flattened her appetite into something theoretical, but she was not going to argue with Donna Price about crackers at 11:30 p.m. Voss had moved to the far end of the nurses' station and was on his phone, speaking quietly with the absolute concentration of someone managing multiple threads simultaneously. Rourke had gone after Briggs. The two civilians who'd arrived with Voss were still at the entrance to the corridor, and Emily had revised her assessment of them. Not security, she thought now. Witnesses. They'd been positioned to observe, and their function was to have seen what they'd seen, which meant Voss had anticipated when he walked through the doors that this would end in some form of formal process. He had come prepared. That was the part that was settling into Emily's chest now, not as suspicion, but as something she needed to understand. She thought about what Donna had said, about the legal folder, about Rourke's badge and the specific agency it represented. She thought about the sequence of events since the patient had come through the doors and the fact that Voss had placed calls before he'd arrived on site, which meant he'd known who was at Redwood Regional before he'd walked in, which meant someone had told him. She took another cracker and thought about that. There was only one person who could have told him. Only one person who had known both Emily's current location and Voss's contact information. She thought about the 7 months she'd been at Redwood Regional, about the hiring process, about the single phone call she'd received from a Navy liaison officer 8 months ago, which she'd taken as routine exit processing and which she now considered in a different light. Someone had been watching where she landed, not surveillance, not anything sinister, just the kind of institutional awareness that large organizations maintain about people whose files are marked a particular way. She knew her file was marked. She had known that when she signed her separation papers. She just hadn't thought it would matter in a civilian hospital in Ashford. Carter. Voss had finished his call. He came to the nurse's station and stood across the desk from her with the posture of someone who has decided to say something directly. "You knew I'd find out where you were," Emily said. He didn't deny it. The liaison office maintains placement tracking for certain separated personnel. Voluntary disclosure, you signed the form in your exit package. I signed a lot of forms. You did. A pause. I wasn't monitoring you. But when I got the call tonight about the patient and the location, I recognized the hospital's geographic area, and I ran a check before we deployed. Standard practice when we're bringing a critically injured officer to a civilian facility. I want to know what we're walking into. And you found me. I found your name on the staff roster. Yes. He met her gaze directly. I won't pretend that didn't affect my preparation for this visit. Emily ate the last cracker in the sleeve and set down the wrapper. Is that why Rourke was already involved when you arrived? You called her before you got here? I called her when I confirmed the patient's status and understood what had happened in the corridor. The interference with emergency care of a military officer by a civilian physician in a facility receiving federal patients is within federal jurisdiction. He said it without satisfaction, just the recitation of a fact. I didn't create that jurisdiction. I reported to it. He was going to let the patient die, Emily said. Not an accusation, just the sentence, placed plainly. He didn't know the patient was going to die. He thought he had the situation managed. He was wrong. Yes, Voss said, and he made decisions based on his wrongness that prevented the most qualified person in the building from intervening until I stepped in. He paused. That's not a small thing, Carter. That's the kind of thing that has a paper trail. Emily understood then, completely. The paper trail had already been built. The security footage, the radio logs, the timestamp on the monitor alarm, Pollard's written statement, the OR record showing the lateral approach that Briggs had needed help to execute. All of it existed. All of it told the same story. Voss hadn't created the paper trail. It had created itself, in the ordinary course of a hospital doing what hospitals do, recording what gets recorded. He had simply ensured that the right people would look at it. She was still thinking through the implications of that when the OR status board changed. Suite 2, patient transferred to ICU. The thoracotomy was complete. The patient was out of surgery. She looked at the board for a moment, then at Voss. What's his name? She asked. The patient. Colonel Dale Harwick, Voss said. Retired. He was at Redwood Regional for a medical conference, civilian work, post-service. Wrong place when a vehicle failed to stop at an intersection 2 blocks from the hotel. Is his family here? Wife is on her way from Portland, should arrive in about an hour. Emily nodded. She thought about Dale Harwick in the ICU now, attached to monitors, breathing through a repaired chest. She thought about the moment in the trauma bay when the alarm had started and she'd been standing in the corridor with Martinez's hand on her arm, watching through the glass. She thought about 11 seconds, because that was what Voss's intervention had bought. 11 seconds between the alarm starting and the decompression being performed. She had timed it. 11 seconds was nothing in most contexts. In that context, it had been the difference between a man who would recover and a man who would not. Carter. It was Rourke coming back down the corridor. She moved quickly, and her expression had shifted from the neutral assessment of someone gathering information to something tighter. I need to inform you that Dr. Briggs has requested that the hospital's legal team conduct their own review of tonight's events before he speaks with me further. That's his right, Emily said. It is. However, Rourke stopped. She looked at Voss, then back at Emily. The hospital's deputy chief of staff, Miss Harlan, has also requested a review of your personnel file and your conduct tonight. She's characterizing your involvement in the OR procedure as an unauthorized assumption of clinical responsibilities beyond your scope of practice. The corridor was very quiet. Emily looked at Rourke, then at Voss, then at the far wall, briefly, while she organized her response. I directed a physician through a procedure, she said. I didn't perform surgery. I verbally guided a technique. That's within the scope of my clinical experience, and it was at the physician's explicit request. That's your position, Rourke said. The hospital's position, as of approximately 10 minutes ago, is that you exceeded your authorized role and that this creates liability exposure for the facility. The hospital's position, Voss said, with a specific quiet that was significantly more dangerous than volume, is going to be very difficult to maintain against a federal incident report, a patient outcome record, and the testimony of the OR team who watched Nurse Carter's guidance result in a successful repair. I understand that, Rourke said. She was watching Emily. But I want you to understand what's happening. The hospital is moving to protect itself. And one of the ways it protects itself is by establishing that any deviation from protocol tonight was an individual action, not an institutional failure. They're going to make it about me, Emily said. They're going to try, Rourke said. I'm telling you because you need to know what's coming. Emily looked at her. Is that professionally appropriate for you to tell me? Probably not, Rourke said. But you saved a man's life tonight under circumstances that were deliberately made harder by the institution you work for, and I've been in this job long enough to think that matters. A beat. Thank you, Emily said. Rourke nodded once and moved away. Voss looked at Emily with the expression of someone who has just watched a situation become more complicated and is calculating resources. Do you have legal representation? He said. I'm a nurse, Colonel. I have malpractice coverage through the staffing agency. That covers malpractice. This is a different category. He paused. The military maintains a JAG support resource for civilians involved in incidents affecting military personnel. I can have someone contacted tonight. Emily was quiet for a moment. The offer was genuine. She could hear that. She was also thinking about what accepting it meant, about the web of obligation and history that came with it, about 7 months of deliberate distance from everything Voss represented, and whether that distance was still possible or whether this night had already collapsed it. Give me the contact information, she said. I'll make my own call. He wrote a name and number on the back of a card and handed it across the desk. Emily put it in her pocket without looking at it. At 12:08 a.m., the hospital's senior nursing supervisor, a man named Gerald Park, who Emily had met once during her orientation and had formed no particular impression of, arrived in the emergency department with the expression of a man who had been woken up and had not enjoyed the experience. He had a tablet and a printed document, and he came directly to the nurse's station. Carter, he said. Yes. I need to speak with you about your conduct during the trauma event tonight. He set the printed document on the desk. Specifically, your unauthorized entry into the OR and your assumption of guidance responsibilities during an active surgical procedure. Emily looked at the document. It had the hospital's letterhead and was dated tonight, which meant someone had drafted it in the last 40 minutes, which meant this was not a routine review, but a prepared response. I was asked to come to the OR, she said, by the OR scrub nurse, relaying a request from the attending surgeon. The attending surgeon has no authority to invite nursing staff into a procedure outside their credentialed scope. The attending surgeon asked for clinical guidance from someone with relevant experience. I provided verbal guidance. I didn't perform a procedure. Park looked at her with the particular tiredness of someone who had been handed a task they didn't choose. The hospital's position is that your actions tonight created a liability situation that we're required to review. Pending that review, your shift assignment is suspended. The room had gone quiet again. Donna was staring at Park with an expression that had moved past neutral into something that was barely being contained. Emily looked at the document. She looked at Park. She thought about Dale Harwick in the ICU. She thought about the lateral approach and the 8 minutes in the OR and the monitor alarm cycling down. "You're suspending me," she said, "pending review." "Tonight." "Yes." She looked at him for a long moment. "There are patients in this department who need care. Bays 4 through 7 are my assignment. 2 of them have open charts. We'll have coverage. Rosa Medina in Bay 7 needs her cervical imaging reviewed before she's cleared for discharge. Her collar sizing is provisional. That needs a direct assessment." "We'll have coverage," Park said again. "I want that documented," Emily said, "that I flagged that specific patient's pending assessment before I was removed from the floor. I want it on record that I raised it and you said it would be handled." Park blinked. Yes, noted. "In writing," Emily said, "on that document you're handing me." He looked at the document. He looked at her. Something shifted in his expression. Not quite recognition, but the early edge of it. The feeling of being in a situation that is not what it was presented to be. He uncapped his pen and made a note at the bottom of the document. Emily took the document. She picked up her jacket from under the desk. She looked at Donna, who was watching her with an expression that had the specific quality of someone who is deciding what kind of person they want to be in this moment. "You know where I am," Emily said to Donna. "I do," Donna said. Her voice was very controlled. Emily walked toward the exit. She was 10 feet from the main doors when she heard it. Not loud, just present. A sound from behind her that made her stop without deciding to stop. It was Pollard. He was standing in the middle of the corridor, and he had his phone out, and on the screen, she could see it from where she was standing because he was holding it in a way that was either oblivious or deliberate, was the security camera timestamp log from the trauma bay corridor. He was looking at it, and he was not alone. The 2 civilians from Voss's team were flanking him, and one of them was recording something on their own device, and the OR scrub nurse, Taryn, had come down from the 4th floor and was standing at the corridor and entrance with her arms crossed and a statement in her hand that she had clearly printed herself. Emily turned around fully. Taryn looked at her. "I typed it on my phone in the elevator," she said. "Signed, dated, and emailed to myself as a time-stamped record. It says that I placed the call to you on behalf of Dr. Briggs, that you came to the OR at his explicit request, and that your guidance resulted in a successful repair of a pulmonary vein laceration." She paused. "I also noted that Dr. Briggs asked for the lateral approach after his initial technique was failing, and that without your direction, the procedure would have required a significantly more invasive intervention with elevated mortality risk." Park was still at the nurse's station. He was looking at Taryn. Taryn looked back at him with the calm, specific expression of a woman who has decided exactly what she's doing and why. "I've also CC'd Colonel Voss's contact and Agent Rourke," she said, "just so everyone has the same information." The hallway held that sentence. Emily stood in the middle of it, jacket in hand, suspended from a shift she'd been working for 7 hours. And she felt something she hadn't expected to feel in this particular moment. Not vindication, not anger, but something quieter and more complicated. The feeling of watching other people decide to tell the truth, without being asked, in a building that had been pretending the truth was negotiable. She was still standing there when Park's tablet chimed. He looked at it. His expression changed. He looked up at Emily, then at Voss, who had come to the corridor entrance and was watching with the stillness of someone who already knows what the message says. Park said, The board chair is requesting an emergency session. His voice had changed register slightly. Tonight, 1 a.m. Emily looked at the clock on the wall. It was 12:17. She put her jacket back on and said to no one in particular, "Then I'll wait." She sat down in one of the plastic chairs along the corridor wall, the same chairs that patients' families used, the same chairs that had been there through every shift she'd worked at Redwood Regional, and she waited. Around her, the hospital continued its night work, the low persistent machinery of care, monitors, and footsteps, and the distant sound of someone being paged. She had been sitting for 4 minutes when her phone buzzed. The number on the screen was not one she recognized. She answered it. "Miss Carter." The voice was unfamiliar, male, formal, with the specific cadence of institutional authority. "My name is Warren Bast. I'm outside counsel retained by the hospital board. I've been asked to contact you regarding the events of tonight." "You're calling me at 12:21 a.m., Emily said. "Yes," Bast said. "I'm aware of the time." A brief pause. "The board has reviewed preliminary footage from the trauma corridor security system. There is some concern about the sequence of events as they have been characterized to this point, and whether those characterizations are accurate." Emily said nothing. "Specifically," Bass said carefully, "there is concern about whether Dr. Briggs's account of the events and the hospital's initial response documentation accurately reflect what the security footage shows." She understood what she was being told. She also understood what she was not being told, the part that lived in the silence around the careful legal language. "Mr. Bast," she said, "you're calling me because the security footage doesn't match Dr. Briggs's account." A pause. "I'm calling because the board wants to ensure that all relevant perspectives are incorporated into tonight's review." "What does the footage show?" Another pause. Longer. "It shows," Bast said slowly, "Dr. Briggs directing a security officer to remove you from the corridor at 21:44. It shows you stating that the patient required immediate decompression. It shows the patient's monitor entering alarm state at 21:46. And it shows—" He stopped. "What does it show?" Emily said. "It shows Dr. Briggs looking through the trauma bay window at the monitor alarm for approximately 8 seconds before re-entering the bay." His voice had gone very flat. 8 seconds during which he was stationary, after you had already told him what was happening. 8 seconds. The same number she had been thinking about all night from the other direction. The 11 seconds Voss had bought. 8 seconds on the other side. 8 seconds in which Nathan Briggs had stood and looked at a dying man's vitals while the nurse he'd removed from the corridor stood in the hallway and watched. 8 seconds that a camera had captured in its entirety. "Mr. Bast," Emily said, "what are you actually calling to ask me?" The pause this time was the longest yet. "The board," he said, "would like to know whether, before they convene their emergency session, there's anything you would like them to understand about your experience and qualifications, specifically as they relate to your ability to assess the situation in that corridor, that is not currently reflected in your personnel file." Emily looked at the corridor, at Taryn's statement, at Pollard standing with the timestamp log, at Voss framed in the entrance to the administrative hallway, watching her with an expression she couldn't read from this distance, but didn't need to. She understood now what the board had found. She understood what 8 seconds on a security tape meant for a physician's career, and for a hospital's liability, and for the legal architecture that Harlan's team had been trying to build around Emily's conduct in the OR. The architecture had a problem. The problem was 8 seconds of footage, and now the board needed to understand, before they walked into a room with Nathan Briggs and his attorneys, exactly what Emily Carter was, and what she'd known, and what she'd said, and what had been done with it. She opened her mouth to answer, and then the lights in the corridor flickered. Once, twice, and every monitor at the nurse's station went dark simultaneously. Donna was on her feet before Emily had fully registered what was happening. The backup generators kicked in, standard hospital protocol, power failure override. But in the 3 seconds before they did, the emergency department was running on nothing. And in those 3 seconds, Emily heard, from somewhere above her on the 4th floor, an alarm that was different from the ones she'd been listening to all night. Sharper, shorter, The specific alarm pattern of a single patient unit losing power and switching to backup. The ICU, Dale Harwick. Emily was moving before she'd finished the thought. The stairs were faster than the elevator, and Emily knew it without calculating it, the way she knew a lot of things about physical spaces, by moving through them repeatedly until the layout became reflex. She hit the stairwell door with her shoulder, took the stairs two at a time, and was through the fourth-floor door in 40 seconds. The ICU at Redwood Regional was at the end of the corridor, past orthopedics and the post-surgical recovery bays, behind a set of double doors that required badge access. Emily had never had a reason to come to this floor on her regular shifts. Her badge cleared the general hospital areas, but not the ICU. She knew that before she tried it, which was why she didn't slow down when she reached the doors. She hit the intercom. "This is Emily Carter, emergency nursing staff. I need access." 3 seconds of nothing. Then, "What is your employee number?" She gave it. Another pause, longer than it needed to be. The door clicked open. The ICU charge nurse was a man named Sutherland. She read the name badge as she came through the doors, broad-shouldered, mid-50s, with the particular tired alertness of someone already managing the situation and not interested in being managed in return. "Who are you?" he said. "Emily Carter, emergency nursing. I was in the OR earlier with Colonel Harwick." "What happened?" Power interruption triggered his vent alarm. Backup kicked in, but there was a 2-second gap in ventilator cycling and his oxygenation dropped. Sutherland was already moving toward the end bay. "He's restabilized, we think," Emily followed. "Oxygenation reading when the alarm fired?" 81. Recovered to 89 on backup power. We're watching for secondary response. 89 was not reassuring for a man 4 hours out of a thoracotomy with a repaired pulmonary vein. The tissue around that repair was bruised and irritated and operating under reduced efficiency, which meant his oxygen exchange margin was already compressed before the ventilator interruption. A sustained drop in saturation at this stage could trigger pulmonary edema, could re-stress the repair site, could do several things in sequence that would be very difficult to reverse. She was thinking through all of this when she stepped into Bay 8 and saw Dale Harwick for the second time. He was intubated, sedated, connected to more monitoring than he'd had downstairs, and the repair she had helped guide was now 4 hours old inside a chest that was doing the quiet, enormous work of beginning to heal. His color was better than it had been on the gurney. Not good, but better. The monitor showed saturation at 91 now, climbing slowly. Sutherland was checking the ventilator settings with the focus of someone looking for the exact parameter that had failed. "Was it a facility power issue or equipment specific?" Emily asked. "Facility. The whole floor dropped. Maintenance is saying a transformer fault in the secondary distribution panel." He looked up from the vent. "We've got backup running. The issue now is monitoring the secondary effects. He's going to need an arterial blood gas in the next 20 minutes to confirm oxygenation isn't being masked by the pulse ox reading. Post-thoracotomy with that saturation fluctuation, the pulse ox could be giving you a cleaner number than what's actually happening in the tissue." Sutherland looked at her. "You said you were emergency nursing." "I am. I have experience with post-surgical trauma management from a prior role." He held her gaze for a moment, doing the assessment that competent people do when they're deciding whether to accept help from someone they don't know. Then he turned to the nurse at the secondary monitoring station. "Get an ABG set up. Let's run it now rather than wait." Emily stayed out of the way while they set it up. She watched the monitor. The saturation climbed to 92 and held there, which was better than it had been and not yet where it needed to be. She watched the waveform on the cardiac monitor. Rhythm was sinus, slightly elevated rate, which was expected at this stage. The chest tube drainage appeared within normal post-thoracotomy range. He was holding. For now. She was watching the drainage readings when she became aware of someone at the bay entrance. She turned. Voss was there, and behind him was a woman she hadn't seen before. Late 40s, dark coat over what looked like travel clothes. A face that was composed with the specific composure of someone suppressing a lot. Her eyes were on Dale Harwick, his wife. She had made it from Portland faster than expected, or the hour had moved without Emily fully tracking it. She looked at the woman, at the deliberate stillness of her, the way she had positioned herself in the doorway rather than coming in, as if entering fully would make the reality of it more real than she was ready for. Emily stepped back from the monitoring station and moved toward the doorway. "Mrs. Harwick?" The woman looked at her. "Yes." "Your husband came through surgery well. The alarm you may have been told about was a facility power issue, not a change in his condition. His numbers are recovering." She said it directly, without softening or inflating. "He's not out of the recovery period yet, but he's stable." Mrs. Harwick looked past her at her husband in the bed. She was quiet for a moment. "Who are you?" "I'm Emily Carter. I'm a nurse on the emergency staff. I was involved in your husband's care tonight." "Involved how?" Emily looked at Voss briefly, then back. "I helped identify the immediate problem when he came in," she said, "and I assisted in the OR during his surgery." Mrs. Harwick was quiet, then, "You helped save his life." "A lot of people helped save his life," Emily said. "I was one of them." Mrs. Harwick looked at her for a long moment with the unflinching directness of someone who has just come very close to the worst possible outcome and has decided to be accurate about everything from here forward. "Thank you," she said. Not effusively, just the words, plainly, like she was placing them down somewhere permanent. "He's going to need you to be steady for the next few hours," Emily said. "The nursing team here will walk you through his status. You can sit with him. Talking is okay, even with the sedation. Familiar voices are generally considered beneficial." She paused. "Do you need anything right now? Water? Somewhere to sit?" "No," Mrs. Harwick said. "I just need to be in there." Emily stepped out of the doorway to let her through. She was back at the monitoring station, reviewing the ABG results that had just come through. Saturation at the tissue level was 90, which confirmed the pulse ox was reading slightly optimistic, but the gap was manageable. When Sutherland appeared beside her. "Your read?" he said. "A BG is acceptable for this stage. I'd increase the FIO too slightly to build a buffer in case the saturation dips again during the night, and I'd set the alarm threshold at 92 rather than 90 so you catch any downward trend earlier." She looked at him. "That's a suggestion, not an instruction. You know this unit." He looked at the ABG results. "It's a good suggestion," he said. He made the adjustments himself. Emily looked at the clock on the ICU wall. 12:41 a.m. She had been in the building for 6.5 hours. She had been suspended from her shift assignment for the last 24 minutes, which meant technically she was not supposed to be in this building at all, let alone in the ICU advising on a patient's care. She thought about that for approximately 3 seconds and then thought about Dale Harwick's ABG results and decided the sequence of those two considerations told her something accurate about her priorities. Voss was waiting for her near the ICU entrance when she came out of the bay. He had the look of someone who had been managing 4 things simultaneously and had resolved 3 of them. "The board session is starting in 12 minutes, he said. "I'm not on the board's schedule." "You are now. Bass called me after he called you. The board chair has requested your presence." He paused. "Not as a subject of review, as a participant." Emily absorbed that distinction. "What changed?" "The footage," Voss said. "And Taryn's statement, and Dr. Pollard's written account, which it turns out is considerably more detailed than anyone anticipated. He documented the pre-shift communication from Briggs where he characterized you as a disruptive agency nurse before you'd had any interaction with the trauma patient at all, which means the decision to discredit you was made before there was any basis for it. He let that sit. The board's legal posture changed when they understood that. "They're moving away from Briggs," Emily said. "They're moving toward accuracy," Voss said, which in this case points away from Briggs. She thought about 8 seconds on a security tape, about a prepared legal document that had been drafted in 40 minutes, about the specific speed with which Park had appeared with his printed form, which meant the hospital's initial instinct had been to close ranks around their chief of surgery rather than look at what had actually happened. "Who's in the room?" she said. "Board chair is a woman named Laura Fontaine. She's had the security footage for the last 30 minutes, and from the tone of the calls I've been on, she's not happy with what she watched." He paused. "Briggs's attorney is there. The hospital's outside counsel, Bast, Rourke, and Major Okafor is the military's formal representative." "Not you?" I'll be outside. He met her gaze. This part isn't mine to be in, Carter. I put the information in front of the right people. What they do with it is the institution's responsibility. She looked at him. You could have called ahead tonight. When you found my name on the staff roster, you could have called the hospital and told them who I was before you arrived. I could have, he said. Why didn't you? Voss was quiet for a moment. Because I didn't want the hospital to change its behavior because of who you were. I wanted what happened to be visible exactly as it happened, without anyone adjusting for your background. He paused. The footage shows what it shows because nobody knew they needed to behave differently. That's a more honest record. Emily thought about that. It was strategically sound. It was also, she recognized, the kind of decision that could only be made by someone willing to let a situation get worse in the short term to make it more legible in the long term. Voss had been willing to let her be removed from the corridor, let the patient's alarm fire, let the whole sequence play out in its worst form, because the worst form captured on camera was the truest testimony. She wasn't sure how she felt about that. She filed it somewhere to examine later, which was where she put most things that required more time than she currently had. Okay, she said. The boardroom was on the second floor, a conference room that looked like it had been designed for quarterly reviews and was now being used for something that would be referenced in deposition filings. Fontaine, the board chair, was a woman in her early 60s with short gray hair and the controlled expression of someone who had spent a career making decisions under scrutiny and had learned to make her face a neutral surface. She looked at Emily when she came in with an assessment that lasted about 2 seconds and revealed nothing. Briggs was at the far end of the table. His attorney, a man named Declan Farr, sat beside him with the practiced positioning of someone who has been in many rooms like this and knows exactly where to place himself. Briggs looked at Emily when she entered. The expression on his face was different from anything she'd seen on it tonight. Not authority, not irritation, not the calculating calm of the OR. Something quieter. Something she might have called diminished, except that seemed too simple. Bast was at the side of the table, the hospital's outside counsel, with the particular discomfort of someone whose legal position had shifted 3 times in the last 2 hours and was no longer sure where it would settle. Rourke and Okafor sat together across from Briggs. Emily took the chair that was left, which placed her directly across from Fontaine. Miss Carter, Fontaine said, thank you for being here. I want to be direct about the purpose of this conversation. The board has reviewed security footage from the trauma corridor between 2140 and 2202 tonight. We've also reviewed a written account from Dr. Pollard and a signed statement from the OR scrub nurse. We have the patient's monitor timestamp records from the nursing station system. She folded her hands on the table. The documentation is clear about the sequence of events. What I want to understand before the board proceeds is the full context. Your background, your qualifications as they relate to what you identified in that corridor. My background is in my personnel file, Emily said. Your personnel file indicates 6 years of military nursing service and 2 combat deployments. It does not specify your role, your unit assignments, or the nature of your clinical experience. Fontaine looked at her steadily. I'm asking you to specify. Emily looked at the table for a moment. Then she looked up. I was a Navy Nurse Corps officer for 6 years, she said. I completed 2 deployments, one in a theater with sustained combat operations, one in a forward staging area during a high-tempo offensive period. For the last 3 years of my service, I was the lead trauma nurse at a forward operating base medical station. We managed casualties from point of injury through damage control surgery and stabilization for transport. In that role, I assisted in over 200 surgical procedures, managed critical care for patients who could not be immediately evacuated, and on 2 occasions performed field interventions under remote physician guidance when no surgeon was physically available. She paused. The pneumothorax I identified tonight was a pattern I've seen more than a dozen times. The lateral approach I guided in the OR is a technique a field surgeon named Mack taught me because we had a casualty with the same anatomical constraint and the standard approach was going to take too long. She looked at Fontaine. I recognized the problem in the corridor. I communicated it clearly. The decision to remove me from the corridor was made by Dr. Briggs after I told him what I believed was happening. The room was quiet. Farr, Briggs's attorney, said, Ms. Carter, you've described an impressive military background, but the question of whether you communicated your assessment clearly is subjective, and Dr. Briggs maintains that your communication was not presented in a manner that the footage, Rourke said quietly, includes audio. Farr stopped. The trauma corridor security system records audio, Rourke said. The board received the full recording, not just the visual feed. She looked at Fontaine. Ms. Carter's exact words, including the specific clinical information she communicated to Dr. Briggs prior to being removed, are on the record. Farr looked at Bast. Bast was looking at his tablet with the careful expression of someone who has just found something he wishes he hadn't. Briggs was looking at the table. Emily watched him. She had been watching him in intervals all evening, in the trauma bay, at the elevator, in the OR, and each time the expression was different. This one was the most stripped down she'd seen. He wasn't performing anything. He was just sitting there with the weight of what the audio recording meant. And what it meant was that every word of his conversation with her in the corridor had been captured. Every word. You're creating a disruption during a trauma activation. I told you to clear the corridor. And hers. That dressing is going to fail in under 3 minutes. The cavity pressure is building. And then the alarm. And then the 8 seconds. All of it. On a recording that the board had been listening to for the past 30 minutes. Dr. Briggs, Fontaine said. He looked up. The board has reviewed the audio and visual record of the trauma corridor from tonight. We have also reviewed the monitor timestamp data showing that the patient's alarm activated at 21:46, which is 2 minutes and 8 seconds after you were informed by Ms. Carter of the pressure buildup she had identified. Fontaine's voice was completely level. The footage shows that following the alarm, you remained stationary at the corridor window for approximately 8 seconds before re-entering the bay. Farr said, the board should understand that in a high-pressure emergency situation, a brief moment of reassessment, the patient had been alerted to as critical by a qualified clinical professional who was then physically removed from the area, Fontaine said. She was not raising her voice. She didn't need to. The question the board is examining is not whether Dr. Briggs paused. The question is whether his decision to remove Ms. Carter from the corridor constituted interference with emergency patient care. And the record suggests that it did. Farr was quiet. Briggs said, I didn't know her background. It was the first thing he'd said in the room, and it came out differently than Emily expected. Not defensive, not deflecting. Just a statement placed plainly. You didn't ask, Fontaine said. He looked at her. No, he said. I didn't. The room absorbed that. It was the most honest sentence Emily had heard him say all night, and she thought that if it had been said 6 hours earlier, in a different context, she might have found it more meaningful. Instead, she found it accurate, and sad in the specific way that accurate things are sad when they arrive too late. Okafor leaned forward. The military's position, which I'm authorized to convey formally, is that the interference with Ms. Carter's involvement in Colonel Harwick's care constituted a preventable delay in critical treatment for a patient under military jurisdiction. The formal incident report has been filed and will be part of any subsequent review by the relevant oversight bodies. He looked at Fontaine. We expect full cooperation from the institution in that review. You'll have it, Fontaine said. She looked at Bast. The suspension of Ms. Carter's shift assignment, issued earlier tonight. What's the current status? Bast looked like a man who had been waiting for this question with something between dread and relief. It was issued under the hospital's standard protocol for pending review of conduct questions. Given the information now available, he paused. The board has authority to rescind it. Consider it rescinded, Fontaine said. She looked at Emily. Ms. Carter, the board apologizes for the action taken against you tonight. It was premature and it was wrong. Emily looked at her. Thank you, she said. I also want to say... Fontaine stopped. She seemed to be choosing something. The footage is difficult to watch. Not because of anything technically egregious, but because you can see very clearly a person telling the truth being sent out of the room. And you can see the consequence of that. She paused. The board takes responsibility for the institutional conditions that allowed that to happen. Emily didn't have an immediate response to that. She had been expecting a review, a reversal, a correction, the mechanical processes of institutional accountability. She had not been expecting Fontaine to sit in a room at 1 a.m. and say something true about what the footage showed. She said, "I appreciate that." Then the door opened. It was Park, the nursing supervisor who had handed her the suspension notice 40 minutes earlier. He came in looking like a man who had been running, which he probably had, and he went directly to Fontaine. "The maintenance team finished the assessment on the power interruption," he said. "It wasn't a transformer fault." Fontaine looked at him. "What was it?" Park set a tablet on the table. On the screen was a maintenance report, and beside it, a work order. Emily could see the header from where she was sitting, could see the date on the work order and the authorization signature, and the department listed under the request field. "The secondary distribution panel serving the fourth floor ICU," Park said, "had a maintenance lockout applied to it at 22:15 tonight. The lockout is a standard safety procedure used during electrical maintenance. It prevents the panel from automatically switching to backup power." He paused. "It's supposed to require a facilities management authorization and a patient safety check before it's applied to any panel serving active clinical areas." Fontaine was very still. "And did it have those authorizations?" "No," Park said. "It had one authorization. The panel lockout was requested and approved by a single department head, bypassing the dual authorization requirement." "Which department head?" Fontaine said. Park looked at the work order. Then he looked at Briggs. The room went absolutely silent. Briggs looked at the tablet. His face had gone the specific color of someone who has felt the ground disappear. "That's not," he started. "The digital signature on the authorization matches your administrative credentials," Park said. He was not looking at Briggs with accusation. He was looking at him the way you look at something you wish you hadn't found. "The request was filed at 22:22. The lockout was applied at 22:48, he paused. 47 minutes after the board session was called. Farr said sharply, "My client categorically—" "The ICU lost power at 12:13, Rourke said. Her voice had changed. It was the voice she used when she had stopped gathering information and started using it. Colonel Harwick's ventilator cycled off for 2 seconds. His saturation dropped to 81. She looked at Briggs. "A man who survived emergency surgery because of the actions of a nurse you tried to remove from the building nearly died again because someone with your credentials authorized a maintenance procedure on the panel serving his ICU bay." The silence in the room had a different quality now. Not the silence of people being careful. The silence of people looking at something they hadn't expected and were struggling to incorporate. Briggs said, "I didn't authorize that." "The digital signature," Park started. "I didn't authorize it," Briggs said, louder. "Someone used my credentials. I haven't accessed the facilities management system in—" He stopped. He looked at Farr. "Someone used my login." Farr put his hand on Briggs's arm. The physical equivalent of stop talking. Rourke was already on her phone, stepping toward the corner of the room. Okafor had leaned back in his chair with the expression of someone who has just understood that the situation has expanded significantly beyond what he came in to manage. Fontaine looked at the work order on the tablet for a long time. Then she looked at Bast. "This is no longer a hospital administrative matter," she said. "No," Bast agreed. "It isn't." Emily sat in the boardroom and looked at Nathan Briggs. He was looking at the table with the expression of a man who has just realized that the evening, which he had believed, perhaps as recently as an hour ago, was a matter of professional embarrassment and manageable consequence, had become something much larger and was still becoming. Whether he had authorized the lockout or whether someone had used his credentials, the outcome was the same. Dale Harwick had nearly died a second time, and Briggs's digital signature was on the document that caused it. The distinction between those two possibilities mattered enormously for what happened next. For what had happened tonight, it did not change the shape of the thing. Rourke came back from the corner. She looked at Fontaine. "I need access to the hospital's digital administration logs for the past 4 hours, specifically the facilities management system access records." "You'll have it," Fontaine said. "I also need to know who else had access to Dr. Briggs's administrative credentials." Fontaine looked at Park. Park looked at Bast. Bast looked at something on his tablet that Emily couldn't see, and the expression on his face when he looked up was the specific expression of a man who has just found a thread, and understood that pulling it is going to be very bad and is about to pull it anyway. The credentials sharing log, Bass said slowly, shows that Dr. Briggs's administrative login was accessed from two separate devices between 2200 and 2300 hours tonight. He looked up. One of them was Dr. Briggs's registered workstation. The other was a device registered to the hospital's facilities department. Who in facilities? Rourke said. The device is assigned to a supervisor named Leo Garrick. Emily didn't recognize the name. She looked at Fontaine, who clearly did. There was a flicker of something in the board chair's expression that was too fast to interpret. Leo Garrick, Fontaine said, has been on the facilities staff for 11 years. She paused. He has also been the subject of 2 internal complaints regarding his conduct toward nursing staff. Both complaints were reviewed and dismissed. She paused again. Both reviews were conducted under Dr. Briggs's department oversight. The thread had been pulled, and what was attached to it was just beginning to come into view. Rourke was already typing. Okafor was on his phone. Bast had the look of a man whose evening was extending in a direction he had not anticipated when he'd been called at midnight. Emily sat very still in her chair and felt the weight of what was accumulating in the room. Not satisfaction, not relief, but the particular heaviness of a situation revealing its actual dimensions after hours of only seeing the surface of it. This had never been only about tonight. The speed with which the suspension notice had been drafted, the prepared legal document, Park arriving with a printed form within 40 minutes, those weren't responses to an unprecedented event. Those were a practiced response. Someone in this building had done this before, or something close enough to it that they had a playbook. Fontaine looked at Emily. Ms. Carter, she said, I'm going to ask you to make yourself available tomorrow morning for a full recorded statement. What you observed, what you communicated, the specific clinical information and when it was shared. She paused. I'm also going to ask for your patience over the next several hours while we determine the scope of what we're looking at. I understand, Emily said. Is there anything you need tonight? Emily thought about the ICU on the 4th floor, about Dale Harwick's ABG at 90 and the FiO2 adjustment Sutherland had made, about Mrs. Harwick sitting in a chair beside her husband's bed. I'd like to check on the patient before I leave, she said. Fontaine nodded. Of course. Emily stood. She picked up her jacket from the back of the chair. She looked at Briggs once more, because the evening had contained enough looking away and she had no taste for it. He was staring at the work order on Park's tablet. He was not looking back at her. She left the room. The hallway was quieter than the boardroom, and she stood in it for a moment, letting her eyes adjust to the dimmer light. Down one end was the stairwell. Down the other was the elevator, and beyond it, the administrative offices where Rourke would spend the next several hours working through access logs and credential records, and the specific digital archaeology of a situation that had turned out to be several situations stacked on top of each other. She took the stairs up to the 4th floor. The ICU was quiet. Sutherland was at the monitoring station, and he looked up when she came through the badge door. His numbers are holding, he said. Saturation 93 and stable. Good, she said. She walked to the window of Bay 8. Through the glass, she could see Dale Harwick in the bed, and beside him, in the chair that had been pulled close to the bedside, his wife. Mrs. Harwick had her husband's hand in both of hers, and she wasn't talking, just sitting there in the specific silence of someone who has arrived at the thing they were afraid of arriving at and has found it survivable. Emily watched for a moment. Then she turned and walked back to the elevator. She was in the lobby, jacket on, badge in her hand, heading toward the parking structure when her phone rang. Unknown number. Again. She answered it. Miss Carter. It was Fontaine. She had left the boardroom less than 10 minutes ago and was already calling from a different line, which meant she was no longer in the formal session and was speaking in a different capacity. I apologize for the hour. It's fine, Emily said. I've just been informed by our IT department that the access log review has identified a pattern. Fontaine paused. This isn't the first time Dr. Briggs' administrative credentials were accessed without his direct involvement. There are 7 previous instances over the past 14 months. All of them correspond to dates when there was a formal complaint filed against a member of the nursing staff. Emily stopped walking. The complaints, Fontaine continued, were filed through the hospital's internal review system. 5 of them resulted in suspensions. 3 of those led to termination. She paused. In each case, the nursing staff member involved had previously filed or was in the process of filing a workplace conduct complaint. The lobby was empty at this hour, except for the security desk and the ambient hum of a building sustaining itself through the night. They were eliminating people who complained, Emily said. It appears so, Fontaine said, and I want you to understand that the board did not know about this pattern. She paused. I also want you to understand that saying we didn't know is not sufficient. We should have known. The data was in our own systems. Another pause. The 5 nurses who were suspended, 3 of them were terminated. We're going to need to contact them. Emily stood in the empty lobby. She thought about Donna, upstairs at the charge desk, who had given her crackers and watched the evening happen with the careful neutrality of someone who had learned to survive in a building with a pattern she maybe hadn't named but had always felt. She thought about Pollard, writing his statement in the corridor. She thought about Taryn, printing a signed account on her phone in an elevator. She thought about the 3 nurses who had been terminated and had no idea that tonight was happening. Ms. Carter, Fontaine said, are you still there? I'm here, Emily said. I want to ask you something directly, and I want you to know you don't have to answer tonight. Go ahead. When this is fully resolved, and it will take time, the formal processes will take time, the board will be looking at significant restructuring of how clinical staff concerns are reviewed. We will need people who understand both the clinical and the institutional dimensions of that kind of reform. Fontaine paused. I'd like to discuss your potential involvement in that process. Not tonight, but soon. Emily looked at the hospital entrance ahead of her. The automatic doors, the parking structure beyond, the ordinary dark of a night that had been going on for a long time. I'll think about it, she said. She pushed through the doors. The night air was cold, and she stood in it for a moment, breathing it in, feeling the shift from the compressed, recycled air of the hospital to something that moved. Her car was 3 levels up in the structure. She started walking. She was halfway across the parking structure's ground level when she heard footsteps behind her. She turned. It was Garrick. She didn't know his face. She'd only heard his name for the first time 40 minutes ago. But he fit the shape of the situation. Facilities uniform, a man who knew the building's systems the way other people know their own homes, who had used that knowledge in specific ways for 14 months and was now somewhere between understood and cornered. He was not large. He was not visibly armed. He was standing 20 feet away with the specific stillness of someone who has made a decision and is living in the moment before it executes. They're looking at the logs, he said. Emily looked at him. I know, she said. His hands were in his jacket pockets. The parking structure was empty except for the 2 of them and the sound of the ventilation system and the distant ambient noise of a city at 1:30 in the morning. This wasn't supposed to go this far, he said. What was it supposed to go? She said. He looked at her with an expression that was hard to read from 20 feet in low light. Not threatening exactly, but the expression of someone who has run out of options and is still standing in the space where the options used to be. Garrick, she said, there are federal agents in that building right now. There is security footage. There's a digital access log with your device ID on it. She kept her voice completely level. Whatever you came out here to do, it's already too late. He stood there. She watched his hands in his pockets, and she thought about 11 seconds, about 8 seconds, about the specific arithmetic of moments when the difference between outcomes is measured in the willingness to stay very still and very clear. Walk back inside, she said, or walk to your car and drive away and they'll find you by morning. Either way, this is over. His hands came out of his pockets. They were empty. He looked at her for a long moment, the specific look of someone who has, in this moment, run out of a particular kind of energy. And then he turned around and walked back toward the hospital entrance. Emily watched him go. She waited until he was through the doors. Then she took out her phone and called Rourke. Rourke answered on the second ring. Garrick just walked back into the building, Emily said. He came to the parking structure. He didn't touch me. I don't think he had a plan beyond whatever he thought a conversation would accomplish. But he's coming in through the main entrance. A pause. Are you okay? Yes. Stay where you are. She heard movement on Rourke's end, heard her say something to someone else in the room. "We've got him." Emily stood in the parking structure and listened to the ventilation system move air through concrete for 30 seconds. Then she put her phone in her pocket and walked to her car and sat in it without starting it. She sat there for a while, not thinking exactly. The kind of not thinking that happens after a long time of thinking very hard, when the mechanism needs a moment before it can do anything else. She looked at the dashboard. She looked at the level of fuel in the gauge. She'd been meaning to fill the tank for 3 days and hadn't. She thought about whether the gas station on the corner of Meridian was open at this hour. She thought about nothing, really, in the way that the mind fills available space with small inventory when the large inventory has been exhausted. Then she started the car and drove home. The formal board hearing happened 9 days later. Not the emergency session. That had been the improvised 1 a.m. accounting that had set the process in motion. The formal hearing was a different thing, a deliberate, documented, structured proceeding in a room that had been arranged for the purpose, with a court reporter and legal representation on all sides, and an outside investigator retained by the board to present findings. Emily sat through 4 hours of it. The findings were not complicated, exactly, but they were extensive. Leo Garrick had accessed Dr. Briggs's administrative credentials 7 times over 14 months using a keylogger installed on a shared workstation in the facilities department, a workstation that had been accessed by Briggs on 2 occasions when he'd been troubleshooting a room maintenance request. The keylogger was not sophisticated. It was the kind of thing a man who understood building systems better than digital security would install, because it worked, and because no one had thought to look for it. No one had thought to look for it because no one had been looking at Garrick at all. He had been, until Emily's phone call at 1:30 a.m., a maintenance supervisor with 11 years of unremarkable tenure and 2 dismissed conduct complaints in his file. The pattern those 7 credential uses revealed was the one Fontaine had described on the phone. Every use corresponded to a period when a nursing staff member had filed or was preparing to file a formal complaint through the hospital's internal system. In 5 of those 7 cases, a suspension notice had been issued shortly after under Briggs's administrative authority. In 3 of those cases, the suspension had been followed by termination. What the investigation could not fully establish, and the outside investigator said this directly, without hedging, was the precise nature of the arrangement between Briggs and Garrick. Whether Briggs had known what Garrick was doing, whether he had asked for it, tacitly accepted it, or been used as an unwitting instrument. The digital record showed Garrick's device. It showed his access. It showed his authorization of the ICU panel lockout. What it did not show was a direct communication between the 2 men that constituted instruction. Briggs maintained under questioning and in writing that he had not authorized any of it. The outside investigator's finding was that the evidence was insufficient to establish direct coordination, but that the pattern of outcomes, the specific targeting of complainants, the use of Briggs's credentials, the speed and consistency of the suspensions indicated that Garrick had been operating with either the knowledge or the deliberate incuriosity of someone who had significant institutional authority and chose not to examine how that authority was being exercised. That finding did not go into a criminal filing. It went into a report that was submitted to the State Medical Licensing Board, the hospital accreditation body, and the Federal Oversight Office that Rourke represented. Garrick was arrested the morning after the parking structure encounter, charged with computer fraud, unauthorized access to protected systems, and interference with medical care of a federal patient. He had retained an attorney by 9 a.m. and had stopped talking by 9:15. What he said before 9:15 had been recorded by Rourke, who is thorough in the way that people are thorough when they have been doing a thing for a long time and have stopped needing to think about the process. Briggs's surgical privileges were suspended by the board on the 3rd day after the formal hearing opened, pending the licensing board review. On the 6th day, he resigned from his position as chief of emergency surgery. The resignation letter, which Fontaine shared with Emily because she felt Emily had a right to see it, was 2 paragraphs. It did not contain the word sorry. It contained the word regrettable twice. Emily read it once and handed it back. "What happens to his license?" she asked. "The licensing board has a review process. It takes time." Fontaine looked at her across the desk. He won't practice at this institution again. Whether he practices anywhere else depends on that process. And the 3 nurses who were terminated. We've contacted all 3. 2 have legal representation and are in discussion with the hospital's counsel about settlement. 1 has agreed to come back. Fontaine paused. We can't undo what happened to them. We're trying to do what's actually possible, which is less than what they deserved. That's honest, Emily said. It's the least I can offer. Fontaine folded her hands. I want to return to the conversation I started in the parking structure 9 days ago. Emily had known this was coming. She'd had 9 days to think about it, and she still hadn't landed on certainty, which was unusual for her. Most decisions arrived with a clarity she trusted. This one kept presenting new angles every time she thought she'd resolved it. I'm listening, she said. The board wants to establish an emergency trauma training program, Fontaine said. Not a supplementary certification, a core component of staff development, something that addresses the gap that was made visible this month. Combat medicine principles, austere environment assessment, non-standard presentation recognition. She paused. We want someone to lead it who has the actual experience, not someone who has read about it, someone who has done it and has also, importantly, demonstrated the ability to communicate clinical knowledge to people who didn't come from the same background. Emily looked at her. You talked Briggs through a procedure in the OR, Fontaine said. A procedure he needed to succeed and was struggling with. You did it under pressure, without condescension, in a way that resulted in a patient surviving. That is a teaching skill. She paused. The military background is necessary. The teaching capacity is rarer. Emily was quiet for a moment. I'm not a physician. The program lead position would typically require... We're adjusting the position framework, Fontaine said. It's a clinical education role, not a direct care role. Your qualifications are appropriate. The board has signed off. She paused. This isn't charity, Ms. Carter. We need someone who can actually do this. You're the person who can do it. Emily looked at the window. Through it was the hospital's east courtyard, a small rectangle of grass and a tree that had been there long enough to have significant presence. She'd walked past it on her way in. She thought about 6 years on active duty, about 11 hours managing 12 patients alone at FOB Keller, about the field surgeon named Mac, who had taught her the lateral approach in a tent with no air conditioning because there was no time for anything except what worked. She thought about Pollard in the corridor, writing his statement with the honest discomfort of a young physician deciding who he was going to be. She thought about what she could do with that impulse if she had institutional space to develop it. Okay, she said. Fontaine looked at her. Okay? Yes. Emily paused. I have conditions. Fontaine almost smiled. I expected you would. The program isn't just for physicians. Nursing staff, techs, respiratory therapy, security, everyone who is in a trauma corridor during an activation. If the problem tonight was that the right information didn't reach the right decision maker in time, then the solution isn't to train only decision makers. She paused. You train everyone who might be the person who knows something that matters. Fontaine was quiet for a moment. That's a significantly larger program than what the board initially outlined. I know, Emily said. It's also the one that actually addresses the problem. Another pause. I'll bring it to the board. I'd also like to review the internal complaint process before I start. The existing system failed 7 people over 14 months. I want to understand how, and I want input on what replaces it. That's outside the scope of the training program. Yes, Emily said. It is. And I'm asking anyway. Fontaine looked at her for a long moment, the same measuring look she'd given her across the boardroom table at 1 a.m. 9 days ago. Then she nodded. I'll arrange it, but Dale Harwick was discharged from Redwood Regional on a Tuesday morning, 3 weeks after the night he'd been brought in. Emily knew because Sutherland had told her. They'd developed a functional professional relationship in the weeks since, the kind that forms between people who have been in an acute situation together and respect each other's competence without needing to make a thing of it. She was in the middle of a curriculum meeting with 2 emergency nurses and a respiratory therapist when her phone showed a text from an unknown number. This is Dale Harwick. I was told you might be somewhere in this building. I'd like to say something to you before I leave if you have 5 minutes. She excused herself from the meeting. He was in the main lobby, standing next to his wife, wearing civilian clothes for the first time. Without the intubation tube and the monitors and the chest tube, he was a different-looking person, still marked by what he'd been through, moving carefully, but present in a way that a person in a hospital bed cannot fully be. His wife was holding a bag that was almost certainly too heavy for her, and he was almost certainly going to carry it in about 30 seconds whether she agreed or not. He saw Emily, and his expression did something that she didn't quite know how to receive. Not gratitude exactly, or not only that. Recognition. The specific look of a person who is seeing, for the first time in full consciousness, the face that belongs to a name they've been told. "Miss Carter," he said. "Colonel Harwick," she said. "You look significantly better than the last time I saw you." He laughed. A careful laugh, the kind you do when your ribcage is 3 weeks out of surgery. "I imagine so." He held out his hand and she shook it. His grip was still strong. Some things came back faster than others. "Voss told me the sequence, most of it. I wanted to hear what I could from you." "There's not much to add to whatever he told you," Emily said. "You came in with a problem I recognized. I said so. It worked out." "He said you were standing in a corridor, that you'd been physically removed from the area." "I'd been escorted to the corridor," she said. "There's a distinction." Harwick looked at her with the same directness his wife had shown 3 weeks ago in the ICU doorway. "Is there?" She paused. "No," she said. "Not really." He nodded. "I've been in enough situations to know the difference between someone who did the job and someone who did more than the job required. You did more than the job required." He paused. "I'm told there's a training program starting." "In 6 weeks. I'd like to make a contribution, not financial. We can discuss financial separately through the right channels. I mean, I'd like to come back and talk to your people. When I'm cleared to travel." He glanced at his wife, who had the expression of someone who has accepted that her husband is going to do this. "I know what it looks like from the other side of that gurney. I think that's worth something in a training context." Emily thought about that, about a room full of emergency nurses and respiratory therapists and security officers listening to a man describe what it felt like to be the patient when the right person was being walked out of the room. About what that kind of testimony did to a training curriculum that she intended to build around the practical and the procedural. "Yes," she said, "it's worth something." He nodded. His wife shifted the bag, and he took it from her without discussion, the automatic coordination of 2 people who have been doing this long enough. He looked at Emily one more time. "Thank you," he said. Not the way people say it when they're completing a social obligation. The other way. She watched them walk through the main doors into the morning. The training program launched on a Wednesday in early autumn in the hospital's largest conference room, which had been rearranged to hold 62 people. Emily stood at the front of it with a presentation she'd spent 4 weeks building and had revised 17 times, the last revision at 11 p.m. the night before when she'd decided the 3rd section was in the wrong order. The room held emergency nurses, surgical techs, 2 attending physicians, 4 residents, including Pollard, 3 security officers, including Martinez, and 8 people from departments she hadn't initially thought to include, but pharmacy, patient transport, radiology, who had contacted her after the program was announced to say they wanted to be there. She looked at the room for a moment before she started. She thought about a forward operating base in a desert, 11 hours, 12 patients, no physician. She thought about a field surgeon in a tent and a lateral approach that worked because it had to. She thought about a corridor and an alarm in 8 seconds on a security tape. She thought about all the things that had been learned through cost, in circumstances that were not designed for learning. She thought about what it meant to put those things in a room like this one, in front of people who might never be in a combat zone, who would work their careers in a civilian hospital, but who would at some point be standing in a corridor with something they knew and someone who needed to hear it. She started talking. She talked for 4 hours, with breaks, with questions, with the kind of digression that happens when a room full of people are genuinely engaging with something, rather than waiting for it to end. Pollard asked 3 questions, 2 of which were better than she'd anticipated. Martinez asked 1 question, about the decision sequence when a physician gives an instruction that a security officer suspects is wrong, that she didn't have a clean answer to and said so, and they worked through it together in front of 60 other people. That was the part, she thought later, that mattered most. Not the procedural content, the recognition patterns, the assessment sequences, the communication protocols. Those were the mechanics. The part that mattered was the room understanding, collectively and in real time, that there was no single person in a trauma corridor who was categorically irrelevant, that the person who knew something might be the physician and might be the nurse and might be the security officer and might be the patient transport tech who happened to have taken a class 8 years ago and happened to remember something, that the title was not the credential, the knowledge was the credential, and the knowledge was distributed unevenly across everyone in that building. After the session ended and the room was emptying, Donna Price appeared beside her with the quiet efficiency of someone who had waited for the right moment. "Well," she said. Emily was stacking materials. "Well, what?" "That was—" Donna stopped. She started again. "7 months ago, you clocked in for the first shift and I handed you a tablet and told you bays 4 through 7 and you didn't say anything except to ask how critical the criticals were." She paused. "I didn't know what to make of you." "Most people don't," Emily said. "I know that now." Donna looked at the room, at the last few people still gathered in small groups at the edges, still talking. "I also didn't know 7 months ago that I worked in a building where people were being pushed out for complaining. I thought I knew this place." "You do know it," Emily said. "You knew enough to give me crackers." Donna almost laughed. "That is a very low bar." "It was the right thing at the right time," Emily said. "That's usually all the bar needs to be." Donna was quiet for a moment, then, "How do you stay calm? In the middle of all of it? How do you actually do that?" Emily looked at her. It was the same question that lived at the end of all of it. The question that people asked when they'd watched someone move through a crisis without fracturing, as if the answer were a technique that could be transferred. "I'm not always calm," she said. "I'm usually scared. I've just had enough experience to know that the scared feeling and the functional behavior are not in competition. You can be afraid and still do the job correctly." She paused. "The training isn't about removing fear. It's about knowing what to do while you're afraid. That's all it's ever been." Donna looked at her for a moment. "That should be the first slide of every session you run." "It's the last slide," Emily said. "Everything else earns it." She put the last of the materials in the bag she'd brought them in. She looked around the room, at the emptied chairs, the evidence of 62 people having been present and engaged and changed in small ways they would carry back into the corridors of this building. She thought about 3 nurses who had been terminated and were now, 2 of them, in settlement discussions that would not give them back what was taken, but would give them something. She thought about Garrick, whose trial date had been set for spring. She thought about Briggs's resignation letter and the word regrettable and the licensing board review that was still in process and would be for months. None of it was clean. None of it had resolved into the simple shape that stories are supposed to resolve into. The institution had failed and was trying to repair itself, and the repair was slow and incomplete and ongoing and would probably always be. Some of the damage was permanent. The 3 nurses who had been terminated, one of them had left healthcare entirely. That was a loss the hospital could acknowledge but could not fix. What you could do was build something better going forward and try to make sure the better thing outlasted the people who built it. That was slower than justice. It was also more durable. Emily picked up her bag. She walked out of the conference room down the corridor, past the trauma bay entrance where 5 weeks ago she had stood in the hallway and watched a monitor alarm begin, and she didn't stop to look at it. She had stopped looking at it weeks ago. Not because she had forgotten what happened there, but because it no longer needed her attention to be real. It had already happened. It was already part of what this building knew about itself. She walked through the main lobby. She pushed through the front doors. Outside, the morning was cool, and the parking lot was full, and the day was continuing in the ordinary way that days continued, full of people who didn't know this story and didn't need to, full of patients arriving and staff changing shifts, and the unremarkable ongoing urgency of a hospital doing its work. She paused on the steps. Not because she needed to, just because she wanted to, for a second, be in the outside air before she went back in. A young nurse she recognized from the second shift. She'd seen her in the hallway during the training session, taking notes, came out through the doors beside her. She had the look of someone who had been on overnight and was now crossing into daylight. She glanced at Emily and then looked again, the small recognition of someone placing a face. "You're the one who ran the training yesterday," she said. "Today," Emily said. "It was today." "Right." The nurse looked tired and uncertain in the way of someone new enough to the job that uncertainty was still the default. "Can I ask you something?" "Sure." "How do you know? When you're in a situation and you can see something is wrong but you're the lowest person in the room, how do you know whether to speak up or whether you're just—" She stopped. "Whether you're wrong." Emily looked at her. The question was the real one, not the procedural version, not the career safety version, the actual question underneath all the others, the one that every person in a corridor with knowledge and no authority eventually had to answer for themselves. "You probably won't always be right," Emily said. "That's the first thing to accept. Sometimes you'll say something and it'll be wrong, and that will be uncomfortable." She paused. "But the cost of being wrong when you speak up is discomfort. The cost of being right when you stay silent is something else entirely." She looked at the young nurse steadily. "Say the thing. Say it clearly, say it once, say it in terms of the patient, not in terms of yourself. And then let the decision belong to whoever has to make it." She paused. "You are not responsible for what other people do with accurate information. You are responsible for whether you give it." The young nurse looked at her for a moment. Then she nodded. Not the automatic nod of someone who has heard advice, but the slower nod of someone integrating something. "Okay," she said. "Thanks." She walked toward the parking lot. Emily watched her go. She thought about what it cost, what it actually cost in the human sense, to be the person who said the thing. In a corridor, in a boardroom, in a parking structure at 1:30 a.m., in a conference room in front of 62 people. It was not a small cost. The idea that speaking truth was costless was one of the more persistent lies that people told themselves, and Emily had never believed it. What she believed was that the cost was worth paying, not because it always worked, not because the right outcome was guaranteed, but because the alternative, silence in the face of something you knew, was a cost too, and a larger one, and it compounded in ways that were harder to see until you were 14 months in and 3 people had lost their jobs and a man was nearly dead on a ventilator. Silence had costs that didn't show on any ledger until they showed everywhere at once. She had paid the price of speaking. She would pay it again. She turned around and walked back into the hospital because she had a second training session at 2 p.m. and she needed to eat something first, and the machine of it, the ordinary forward motion of the next thing and the thing after that, was both the smallest possible version of what any of this meant and also, in its own way, the whole of it. Training doesn't eliminate fear. It just makes sure fear doesn't get the last word.